In the neonatal population, congestive heart failure represents a clinical syndrome rather than a single diagnosis. The essential feature is inadequate cardiac output to meet metabolic needs, despite elevated filling pressures. Increased end diastolic pressures impair venous return, producing pulmonary and systemic congestion. The combination of reduced perfusion and elevated venous pressure manifests as respiratory distress, poor growth, and systemic edema. The underlying process is progressive, with neurohormonal activation and molecular changes further weakening cardiac performance. Clinically, it is important to recognize that neonatal CHF may present with subtle signs before overt failure develops. Early identification enables timely treatment and prevention of end organ compromise. When CHF occurs in utero, it typically manifests as hydrops fetalis. Several mechanisms can overwhelm the fetal heart. Severe anemia, as seen with twin-to-twin transfusion syndrome, forces the myocardium to sustain very high output. Persistent tachyarrhythmias, such as supraventricular tachycardia or heart block, reduce effective stroke volume and precipitate heart failure. Intrauterine myocarditis compromises contractility. Large arteriovenous malformations or structural lesions, like an absent pulmonary valve, increase circulatory load. Premature closure of the ductus arteriosus, sometimes triggered by maternal prostaglandin inhibitor use, abruptly alters fetal hemodynamics and can be catastrophic. These fetal presentations often lead to prenatal detection, but survival hinges on rapid postnatal stabilization and targeted intervention. In the newborn period, structural congenital heart disease accounts for the majority of CHF, nearly 60% of cases. Left-to-right shunt lesions, such as ventricular septal defect, patent ductus arteriosus, or atrioventricular canal led to pulmonary overcirculation and volume overload of the left heart. Left-sided obstructive lesions, including coarctation of the aorta, critical aortic stenosis, or hypoplastic left heart syndrome, reduce forward systemic flow and trigger failure. Myocardial disease, whether from myocarditis or primary cardiomyopathy, impairs contractility. High-output states such as severe anemia, systemic infection, or arteriovenous malformations overwhelm even structurally normal hearts. Recognizing the underlying category, shunt, obstruction, myocardial dysfunction, or high-output state, guides immediate stabilization and informs long-term management. The onset of CHF symptoms is tied closely to circulatory transitions after birth. Infants with large left-to-right shunts often appear stable at delivery, but as pulmonary vascular resistance falls over the first days and weeks, pulmonary blood flow rises and CHF becomes evident. Obstructive lesions may remain silent until the ductus arteriosus closes, usually within the first 72 hours, at which point systemic output drops precipitously. Myocardial disorders such as myocarditis or cardiomyopathy present variably, often within the early postnatal period, sometimes with acute decompensation. When CHF arises in utero, hydrops fetalis may be detected before delivery or evident immediately at birth. For clinicians, knowing when to expect deterioration is critical for surveillance and timely intervention. The earliest sign of neonatal CHF is often tachypnea, reflecting pulmonary edema. Tachycardia is common, with resting heart rates between 160 and 180 beats per minute. Feeding difficulties are a hallmark. Infants may take prolonged periods to finish feeds, frequently accompanied by diaphoresis. Hepatomegaly reflects systemic venous congestion. Auscultation may reveal fine or coarse crackles consistent with pulmonary fluid overload. Cyanosis can occur depending on the underlying lesion. Chest radiographs often show cardiomegaly. Blood pressure measurements across 4 extremities may uncover obstructive lesions, such as coarctation, with differential pressures between upper and lower limbs. Recognizing this constellation of findings allows differentiation of CHF from isolated pulmonary disease and directs attention to underlying cardiac pathology. Effective management of neonatal CHF begins with treating the underlying cause whenever possible. Supportive care is directed at reducing metabolic demand and optimizing oxygen delivery. Minimizing handling, correcting acidosis, and providing supplemental oxygen when hypoxemic all reduce cardiac workload. Nutritional strategies emphasize fluid restriction while increasing caloric density to support growth without exacerbating volume overload. Pharmacologic therapy addresses hemodynamic derangements. Diuretics relieve pulmonary congestion, digoxin enhances contractility and controls atrial arrhythmias, and angiotensin-converting enzyme inhibitors lower afterload and reduce maladaptive remodeling. Inotropes such as dopamine or dobutamine are reserved for severe decompensation. These interventions require careful titration and continuous reassessment at the bedside to balance efficacy with risk. Therapies for Swiss francs can themselves create complications. Digoxin toxicity may present with vomiting, dysrhythmias, or bradycardia requiring vigilant monitoring of drug levels and electrolytes. Loop diuretics, though effective for fluid removal, predispose infants to hypokalemia, hyponatremia, hypomagnesemia, and hypocalcemia. Chronic use is linked to metabolic bone disease, nephrocalcinosis, and even ototoxicity. Angiotensin-converting enzyme inhibitors may cause hypotension, renal impairment, or dangerous hyperkalemia. Inotropes increase myocardial oxygen demand and can precipitate tachyarrhythmias. The complexity of neonatal physiology amplifies these risks. Safe practice requires meticulous surveillance of fluid balance, renal function, electrolytes, and rhythm, with early recognition of adverse effects to adjust therapy promptly. Medication choices in neonatal congestive heart failure. Target preload, afterload, contractility, and rhythm to relieve respiratory distress, support growth, and prevent organ injury. Diuretics are first line when pulmonary congestion or systemic edema predominates. By lowering intravascular volume, they reduce preload and improve work of breathing and feeding tolerance. Close monitoring of electrolytes, urine output, and renal function is essential. Angiotensin-converting enzyme inhibitors, AC inhibitors, reduce afterload and improve forward output while countering neurohormonal activation that promotes ventricular remodeling. Start at low dose and titrate cautiously with blood pressure, creatinine, and potassium surveillance. Digoxin is useful when depressed systolic function or atrial tachyarrhythmias are present. It increases contractility and slows atrioventricular nodal conduction for rate control. But the therapeutic window is narrow. Dose by weight and renal function, time drug levels appropriately, and watch for early toxicity such as vomiting or new conduction changes. Beta-adrenergic blockers can help in selected infants by improving diastolic filling time and controlling tachyarrhythmias, but require caution because of bradycardia and hypoglycemia risk. Vasodilators are reserved for hypertensive crises or marked afterload excess. Agents such as nicardipine or nitroprusside reduce systemic vascular resistance and must be used with continuous hemodynamic monitoring. Across classes, the goal is consistent: optimize cardiac performance while minimizing adverse effects. Pair medication therapy with supportive care that lowers oxygen demand, ensures adequate calories without excess fluid, and reassesses response at the bedside. Understanding the nephron is essential to explain how diuretics relieve congestive heart failure. Loop diuretics act on the thick ascending limb of the loop of Henle, blocking sodium, potassium, and chloride reabsorption, which drives water excretion and acutely reduces preload through both diuresis and venodilation. Thiazides target the distal convoluted tubule, producing milder natriuresis while conserving calcium, making them suitable for chronic management or combination therapy. Potassium-sparing diuretics act at the collecting duct by antagonizing aldosterone, promoting sodium excretion while retaining potassium and magnesium. Sequential nephron blockade, such as combining a loop with a thiazide, can enhance overall diuretic effect, particularly in infants with refractory volume overload. This framework explains why each class is chosen and how their sites of action correspond to the pathophysiology of fluid retention in neonatal heart failure. Furosemide, the most commonly used loop diuretic in the NICU, works by targeting the sodium-potassium 2-chloride cotransporter in the thick ascending limb of the loop of Henle. By blocking this transporter, sodium and chloride reabsorption are interrupted, leading to increased delivery of solute to the distal nephron. This obligates water excretion, producing a potent diuretic effect with significant reduction in circulating volume. The rapid diuresis lowers left atrial and ventricular filling pressures, relieving pulmonary congestion and systemic venous congestion. A unique property of loop diuretics is their ability to cause venodilation even before diuresis occurs. This acute reduction in venous return decreases preload and provides rapid symptomatic relief of dyspnea in infants with pulmonary edema. Their potency makes them more effective than thiazide or potassium-sparing diuretics, but also more prone to cause electrolyte depletion, metabolic alkalosis, and nephrocalcinosis. Because of these risks, close monitoring of electrolytes, renal function, and urine output is essential, especially in preterm infants who are more susceptible to bone mineral loss. Clinically, furosemide is often the first pharmacologic step in symptomatic neonatal heart failure. The therapeutic goal is improved oxygenation, feeding tolerance, and weight gain through relief of pulmonary edema and systemic congestion, while minimizing complications from excessive volume depletion or electrolyte shifts. Furosemide is the primary loop diuretic used in neonates when rapid fluid removal is needed. In congestive heart failure, left-to-right shunts or impaired myocardial function increase venous pressures and preload, leading to systemic and pulmonary congestion. By reducing intravascular volume, furosemide alleviates hepatomegaly, edema, and feeding intolerance. In pulmonary edema, particularly when elevated left atrial pressure transmits back into the pulmonary veins, furosemide lowers hydrostatic pressure and improves gas exchange. This reduces tachypnea, oxygen requirement, and work of breathing. Chronic lung disease often includes interstitial fluid retention that worsens compliance. Furosemide enhances pulmonary mechanics by decreasing extravascular lung water, although prolonged use must be balanced against risks of metabolic bone disease and nephrocalcinosis. In renal edema, such as nephrotic states or acute renal compromise, impaired sodium handling leads to fluid accumulation. Loop blockade directly promotes natriuresis and restores volume balance. Because of its potency and rapid onset, furosemide is the first-line diuretic for acute heart failure in neonates. Its combined effects of diuresis and venodilation produce quick relief of preload-related symptoms, while clinicians address the underlying cardiac lesion. Careful titration and monitoring are required to avoid excessive diuresis, electrolyte loss, or ototoxicity. Furosemide dosing in neonates must be individualized to both the acuity of illness and the underlying physiology. For intermittent therapy, the typical intravenous or oral dose ranges from 0.5 to 2 milligrams per kilogram every 6 to 12 hours. The wide interval reflects the variable half-life in neonates, which is prolonged in preterm infants and shortened in older infants. A maximum single dose of 6 milligrams per kilogram is rarely required, but is sometimes used in severe fluid overload or diuretic resistance. Intravenous administration is preferred in acute decompensation because rapid delivery provides immediate effect and predictable absorption. Continuous infusion, generally between 0.05 and 0.4 milligrams per kilogram per hour, may be chosen in critically ill infants with refractory edema or when stable diuresis is needed without large shifts in intravascular volume. For chronic management, oral dosing is typically sufficient, though absorption can be erratic, particularly in preterm infants with gut immaturity. Clinicians must titrate the regimen to maintain fluid balance while minimizing risks of electrolyte depletion, nephrocalcinosis, and bone mineral loss. Whether intermittent or continuous, therapy requires close bedside monitoring of weight, urine output, electrolytes, and renal function. The potent diuretic effect of furosemide comes at the cost of predictable complications that require vigilant monitoring in the NICU. Electrolyte abnormalities are common because sodium, potassium, and chloride reabsorption are blocked in the loop of Henle. Hyponatremia, hypokalemia, and hypochloremia can all precipitate arrhythmias or feeding intolerance if not corrected promptly. Excessive fluid removal may cause hypovolemia and dehydration, leading to hypotension and reduced perfusion of vital organs. Ototoxicity is a specific concern with loop diuretics, particularly when given in high doses or as a rapid intravenous bolus. This manifests as hearing loss, which may be transient or permanent, and is more likely with concurrent aminoglycoside therapy. Prolonged use can also injure the kidneys, contributing to nephrocalcinosis and renal impairment. Because hydrogen ion excretion is enhanced, metabolic alkalosis can occur, further aggravating electrolyte instability. At the bedside, therapy must always be paired with structured monitoring. Daily weights and urine output track volume status. Serum electrolytes and renal function identify early shifts that require intervention. Audiology screening may be indicated for infants with extended exposure. By linking monitoring directly to mechanism of toxicity, clinicians can maximize benefit while minimizing risk. Hydrochlorothiazide is the most frequently used thiazide diuretic in neonates and works at a different site than furosemide. By inhibiting the sodium chloride cotransporter in the distal convoluted tubule, it promotes modest natriuresis and water loss. The effect is less potent than loop diuretics, but sufficient for maintenance therapy. A key advantage of thiazides is that they are calcium-sparing. Unlike furosemide, which increases urinary calcium excretion and contributes to bone demineralization and nephrocalcinosis, hydrochlorothiazide reduces calcium loss in the urine. This makes it particularly valuable for long-term use in preterm infants who already face risks of osteopenia and impaired mineralization. Clinically, hydrochlorothiazide is best suited for chronic management of fluid retention in congestive heart failure or chronic lung disease. It is often combined with a loop diuretic when resistance to loop therapy develops, as the sequential blockade of sodium reabsorption sites produces a synergistic effect. The usual dose is 1 to 3 milligrams per kilogram per day, given orally every 12 to 24 hours. While not as powerful in acute decompensation, thiazides are an important option for long-term control where daily stability and lower risk of electrolyte depletion are priorities. Careful monitoring of electrolytes and growth remains essential, but thiazides offer a safer profile for extended use compared with loop agents. Spironolactone is a potassium-sparing diuretic that works by antagonizing the aldosterone receptor in the distal nephron. By blocking aldosterone, it prevents sodium reabsorption and potassium excretion. The result is modest natriuresis with retention of potassium and magnesium. The major advantage of spironolactone is its ability to offset the electrolyte losses caused by loop or thiazide diuretics. In neonates requiring chronic diuretic therapy, especially those on furosemide, it helps reduce hypokalemia and hypomagnesemia while contributing to overall fluid balance. Because the diuretic effect alone is weak, spironolactone is rarely used in isolation. Its value lies in combination therapy, where it supports electrolyte stability and adds a mild diuretic effect. The typical neonatal dose is 1 to 3 milligrams per kilogram per day, divided every 12 to 24 hours by mouth. The most important safety consideration is the risk of hyperkalemia, particularly when used together with angiotensin-converting enzyme inhibitors, which also impair potassium excretion. For this reason, monitoring must include regular checks of serum, potassium, renal function, and acid-base status. At the bedside, spironolactone is often continued for long-term management of chronic lung disease or congenital heart disease when loop diuretics alone are insufficient. Its role is supportive, preventing dangerous electrolyte shifts while maintaining more consistent volume control. Angiotensin-converting enzyme inhibitors, or ACE inhibitors, are central agents in the management of neonatal heart failure because they act on both preload and afterload. Their primary mechanism is inhibition of the conversion of angiotensin 1 to angiotensin 2. This reduces vasoconstriction in the systemic circulation, lowering afterload and allowing the ventricle to eject blood more effectively. By decreasing angiotensin 2 levels, aldosterone secretion is also reduced. The fall in aldosterone leads to less sodium and water retention, which lowers preload and minimizes pulmonary and systemic congestion. This dual reduction in loading conditions directly improves forward cardiac output. Beyond hemodynamic effects, ACE inhibitors have cardioprotective benefits. In the setting of chronic pressure or volume overload, angiotensin 2 promotes maladaptive hypertrophy and remodeling. Blocking this pathway helps preserve myocardial geometry and function over time, which is particularly important for infants with congenital lesions or ventricular dysfunction who require prolonged medical management. For these reasons, ACE inhibitors are considered standard therapy for neonatal heart failure. Their use requires careful initiation and titration with close monitoring of blood pressure, renal function, and electrolytes, but when applied thoughtfully, they provide durable improvement in both symptoms and long-term myocardial health. ACE inhibitors are considered standard therapy in neonatal congestive heart failure because they reduce both preload and afterload, improving cardiac output while blunting neurohormonal activation. Their ability to prevent ventricular remodeling makes them especially important for infants with chronic volume or pressure overload. They are also used in hypertension, particularly when renovascular disease is suspected. In this setting, reducing angiotensin II-mediated vasoconstriction directly addresses the mechanism of elevated blood pressure. In ventricular dysfunction, whether following ischemic injury, myocarditis, or as part of a congenital lesion, ACE inhibition supports forward flow and helps prevent progressive dilation and hypertrophy. Beyond cardiac indications, ACE inhibitors provide renal protection by reducing intraglomerular pressure and proteinuria. This benefit is most relevant in infants with congenital renal anomalies or those exposed to long-term nephrotoxic therapies in the NICU. Because of these combined effects, ACE inhibitors are recognized as first-line agents for heart failure with reduced ejection fraction. In neonates, the principle is the same as in older children and adults, though dosing must be cautious and monitoring frequent due to a heightened risk of hypotension and renal dysfunction. Captopril is the preferred ACE inhibitor in neonates because of its short half-life, which allows for flexible titration and safer discontinuation if adverse effects occur. The typical oral dose ranges from 0.01 to 0.5 milligrams per kilogram every 8 to 12 hours. Starting at the lowest end of the range is essential, as neonates are particularly sensitive to abrupt reductions in blood pressure. The short half-life becomes an advantage in this population since drug exposure can be quickly adjusted in response to hypotension, renal impairment, or electrolyte disturbances. This makes Captopril more forgiving than longer-acting agents such as Enalapril. Careful monitoring is required, with attention to serum creatinine and urine output to detect early renal dysfunction. Hyperkalemia must be watched for as aldosterone blockade reduces potassium excretion. Clinicians should avoid co-administration with potassium-sparing diuretics unless there is very close laboratory surveillance. At the bedside, Captopril is most useful for infants with heart failure from left to right shunts or ventricular dysfunction who require afterload reduction. The combination of predictable effect, rapid onset, and short duration provides both efficacy and safety in the fragile neonatal population. Enalapril is an ACE inhibitor with a longer half-life than Captopril, allowing for less frequent dosing in neonates. The typical oral dose ranges from 0.05 to 0.1 milligrams per kilogram every 12 to 24 hours. The extended duration makes Enalapril suitable for maintenance therapy, particularly in infants who have stabilized after acute heart failure or who require chronic afterload reduction. An intravenous formulation is also available, which can be used in acute situations where oral administration is not feasible or rapid titration is necessary. Although it has a longer half-life, clinicians must remain vigilant for hypotension and renal dysfunction, as neonates are highly sensitive to reductions in systemic vascular resistance. Enalapril serves as an alternative to Captopril for infants who have tolerated initial stabilization with a shorter-acting agent. The decision between Captopril and Enalapril is guided by the clinical context. Captopril for acute titration and rapid adjustment, Enalapril for consistent maintenance therapy. Monitoring includes serial blood pressure, renal function, and electrolytes, particularly potassium, to ensure safe and effective therapy. ACE inhibitors can produce several clinically important adverse effects, and understanding the mechanism of each guides safe administration. Hyperkalemia arises because aldosterone secretion is reduced, limiting potassium excretion in the distal nephron. Infants with immature renal function or those receiving potassium-sparing medications are at higher risk, necessitating frequent monitoring of serum potassium. Acute kidney injury may develop when intravascular volume is low or renal perfusion is compromised. By decreasing efferent arteriolar tone, ACE inhibitors reduce glomerular filtration pressure, which can precipitate or worsen renal dysfunction. Hypotension is most pronounced with the first dose due to the sudden reduction in systemic vascular resistance. Initiating therapy at the lowest dose and titrating upward allows circulatory adaptation while maintaining organ perfusion. Cough is less common in neonates than in adults, possibly due to reduced sensitivity of pulmonary irritant pathways. But new respiratory symptoms should be evaluated. Angioedema is rare, but potentially life-threatening and requires immediate discontinuation and intervention. Therapy should always begin with the lowest effective dose, with careful monitoring of blood pressure, renal function, and electrolytes to maximize benefit while minimizing predictable complications. ACE inhibitors are contraindicated in conditions where renal perfusion is critically dependent on angiotensin II. In bilateral renal artery stenosis, blockade of angiotensin-converting enzyme can precipitate acute kidney injury because the efferent arteriolar constriction that maintains glomerular filtration is removed. Severe aortic stenosis is another contraindication, as afterload reduction may further compromise forward flow in an already obstructed left ventricular outflow tract. Hyperkalemia greater than 5.5 milliequivalents per liter is also a contraindication, since ACE inhibition further reduces potassium excretion and can precipitate dangerous arrhythmias. ACE inhibitors are teratogenic and therefore should be avoided during pregnancy. Monitoring focuses on parameters that reflect the mechanisms of drug action. Renal function, including serum creatinine and blood urea nitrogen, detects early reduction in glomerular filtration. Electrolytes, especially potassium and sodium, must be followed to prevent hyperkalemia or hyponatremia. Blood pressure should be measured regularly to avoid excessive hypotension, which can reduce organ perfusion and exacerbate renal compromise. Careful monitoring allows safe administration while maximizing hemodynamic and cardioprotective benefits.